right. Good morning, everybody. It's February 3rd, 2026. It's 9:08 a.m. And we will call this work session to order. Our first order of business is the Pledge of Allegiance. So if you can stand and join me, appreciate it. Okay, thank you. All right, the first item on our agenda here is discussion on healthcare assistance program and proposed revisions. And so that I'll turn it over to Ms. Jamie Michael. Good morning.
Good morning, Mr. Chair. Good morning, Commissioners. Jamie Michael, County's Health and Human Services Department. Pleased to be with you today to discuss this program. This really is one of the cornerstone programs of the county and most definitely of our department because it is one of the things that we are required to do as county governments. All 13 counties have some version of this. Obviously, the Bernalillo County, that four-county area with Valencia and that central part of the state is much different, but all the rest of the counties generate a gross receipts tax that is dedicated to this purpose, and there's a convoluted state statute that guides it and also county resolution. So here today to talk about some proposed changes to our healthcare assistance program, formerly known as the indigent program, but we really try to reframe it in a more positive language. So you'll hear me refer to healthcare assistance or HCAP program. The requirements, again, it is governed by both state and county level. So the state statute requires that the person be living in our county. It doesn't matter if they've been living here a day or 80 years, they have to have an address in our county. The state statute outlines a maximum income so people cannot make too much money. It also defines someone who is, again, they use the word indigent, as someone who has current income and assets to pay for their regular living expenses. So there is a requirement to demonstrate current income and assets. It also does not allow us to use these funds for things that are Medicaid reimbursable. So we cannot use it for services that Medicaid would cover. The county resolution, or where the statute gives counties the ability to make their own rules and policies, is we get to decide the type of services. So the statute says healthcare, and it gives a very broad list of those services. The county gets to define what services you want to cover with county dollars. It allows us to determine the evidence of eligibility. So the state says you can't make more than this. The county gets to decide what the evidence of that documentation is to demonstrate that. The county also gets to decide if we are the payer of last resort. This has been historically used for our program and for most other, as far as I know, all other county indigent programs. Although the state statute doesn't specifically say payer of last resort, it says you can't use your money to pay for things that are eligible under Medicaid. But the county, for as long as I've been here, and I think the paperwork I've seen prior to me, we've always used the terminology payer of last resort. And now the state statute does allow us to include premium assistance if you'd like. So the county has the ability to make decisions around premium and other out-of-pocket costs related to helping people gain coverage. So today we're going to look at that column, county resolution, all the things that we can, or that you all can influence. So the first is the types of services. Our recommendation is that we maintain primary care, dental, behavioral health, end of life, and some of the limited orthopedic and physical therapy. The primary care and dental care, behavioral health can all be very upstream approaches, and we want to keep people healthy. One of the primary goals is that people don't, their health doesn't deteriorate so much that they're in and out of emergency departments. So we really hope that we will continue to provide those services to folks. The end of life, it's a very small percent of people, but at the end of life, if you don't have insurance that's covering your residential care, and we have some wonderful hospice services in our community, so we've always included that. The orthopedic and physical therapy, that came about from several community meetings talking about people who, the most common example was you break a bone, you go to the emergency department, they will cast it for you and send you on your way. The individual then will uncast it and will lose functionality oftentimes, so then they're not able to return to the workforce. So if we can spend a little bit of money and help people access orthopedic and physical therapy, then we did a pilot project, and their functionality and ability to return back to work was greatly increased. So those services have been included again for as long as I've been here, and it was because of the community need and demonstrating kind of that particular scenario. Some changes. After a recent conversation with Stephen, at this point, we will not be using indigent funds for ambulance transport. We do currently have a contract with MMC for cancer treatment. I'm going to be asking Carrie and the legal team to take a look at the lease agreement, because I think it should be covered under the lease agreement versus in the indigent fund. And again, a change, we can now provide premium assistance or out-of-pocket costs. So we're going to, again, focus on some of those changes. The evidence of eligibility, this is currently in the resolution, and for the most part, this seems to be working. We have refined it a bit after meeting with our HHS Alliance and our advisory board and some of the eligibility staff that do this work every day. But there is a list of documents that are allowable to prove that you are who you are. So the first thing is, if you say you're Jamie Michael, we need something to show that you are Jamie Michael. We have the last part of that there. In some situations, if there's not a photo ID, we do allow a declaration of identity. A lot of times people in hospice care, sometimes people in behavioral health care, or younger people don't have a photo ID. So we were allowing the provider to do a declaration of identity. Residency, we want to make sure you live here. There's, again, a list of documents. And again, primarily because we had some advocates from Community of Hope and Gospel Rescue Mission come and say not everyone has these documents. So we are allowing an affidavit from a service provider agency to say, you know, Jamie lives at Community of Hope, or some scenario like that. Additional evidence of eligibility, current income. There's a long list of things there that people can provide. You only need to provide one of these to show current income. We're trying to be as broad as we can, but still be accurate and look for some type of document that wasn't just created by me writing down my income, something that has some background and some legitimacy behind it. The max income, it is again defined in the statute, and we have to use the Department of Commerce, the U.S. Department of Commerce. The commission determined years ago that the annual tax return is the most accurate way to determine your maximum income. So that's what we've continued to use. And then we need to have some conversations about how do you prove that you are the payer of last resort. Obviously, if you're eligible for Medicare or Medicaid, we wouldn't be the payer of last resort. If you have insurance offered to you by your employer, or if you're able to purchase insurance on the exchange. And payer of last resort became a little stickier when the Supreme Court removed the mandate under the Affordable Care Act, because it was very clear under that everyone was required unless, and there was a very clear list. Now that that mandate is not part of the Affordable Care Act, it makes it a little trickier for us. The reason that we have all of these clear list of documents for eligibility, Many years ago, gosh, Deb, I think it's at least 10 years ago, we had an internal audit. And at that time, the program was even broader than it is now and allowed a variety of documents, and it wasn't codified in a resolution, so sometimes it was up to individual employees. And there were a lot of accusations of fraud. None of it was proven, but there were a lot of accusations of fraud. So the commission at that time narrowed all of the evidence of eligibility. All of the requirements became a little more rigid, and again, they were put in a resolution. Over the years, we've come back and asked for it to be a little broader, a little looser, a little more encompassing as we've learned specific scenarios. So that is how we got to the place where we are with all of the evidence of eligibility. Now, the payer of last resort, again, what we currently do and historically have done is if you are eligible for any other coverage, or if your coverage does not, if you're not eligible for any other coverage, or your coverage does not include the needed services, then you would qualify for our program. So my first question to you all is, do we want to remain the payer of last resort? The recommendation from staff, from our alliance, which is our advisory board, and they created a subcommittee of eligibility specialists from multiple organizations. We're saying that if a person qualifies for any of the following, they would not qualify for the HCAP program. So if they have an employer-based insurance, they should be utilizing that. If they have TRICARE, Medicare, Medicaid. The only exception is if the available coverage for the individual is more than 8% of their monthly income. So if you can purchase insurance on the exchange, which most people can, but it's going to be so costly that it's going to cost you more than 8% of your monthly income, we're considering that not accessible. So you may be eligible for it, but it's not feasible. So the county could be the payer of last resort. The 8% is kind of a national standard used for national and state programs that documents affordability. And Deb, I believe that's also for employers, the 8%. So it's not a standard that we made up or are just applying to HCAP. It's a standard that's used across a variety of industries. For example, Doña County cannot charge me as an employee more than 8% of my monthly income for my health insurance premiums. So I don't know if you want me to stop there and we have a discussion about payer of last resort, or you want me to complete the whole thing and you all just kind of keep track of the policy questions that we have for you all today.
I don't know, commissioners, part of me would think let's maybe go through the whole presentation, because I think there's going to be several topics that we'll probably dive into, but I don't want to quite derail the presentation. But like I said, unless anybody has an urgent question at this point, not like I said, we'll hold our questions a little bit so we can kind of go into the different parts here.
Perfect, perfect. And some of them might be kind of interdependent. So the next question for you all is the inclusion of premium assistance. And again, I'm saying premium assistance, but it can be broader. It can be any out-of-pocket costs related to accessing healthcare coverage. So the first question is, should the healthcare assistance program include premium assistance? Our recommendation is yes, if we work with the New Mexico Medical Insurance Pool. And the reason that is insurance that is full coverage. There is no citizenship requirement, whereas purchasing insurance on the exchange, there is a citizenship requirement. It has to meet the same network adequacy standards as any commercial insurance, and they do cover El Paso. So we did ask that specific question because it's not going to be, that useful for people here if they can't also cover providers in El Paso. And they also have a sliding fee based on income. So depending on the individual's income, they will be eligible for a variety of discounts. So if yes, the next question is how much money should we allocate to that program, and then work on how do we design that program. Here's a scenario that just describes one model. So if there is a single adult, age 53, and single adult doesn't mean not married, no children, it just means that that's the individual we're covering. So they still might be part of a family, but we're only covering individual insurance. We're not providing family coverage. So if that individual, age 53, makes $2,000 a month, has no other coverage, and qualifies for the program, so they still have to meet all the other criteria, and they have a chronic condition needing ongoing specialty care, then we look at how much it would cost for them to access insurance through the exchange, and I can show you that table here. But when we looked at this 53-year-old, it was going to cost them $440 a month for the $500 annual deductible plan. So what we're recommending is that the individual pays 8% of their income. So that would be, they would pay $160 towards the deductible, towards the premium, and the county would pay the remainder, $280 a month. So we pay anything over the 8%. That way it's fair wherever you are on that income scale. Everyone is responsible for up to 8%, and the county pays the additional. And I don't know if we brought, but last time we talked, we showed you the income guidelines for the county's program, so it can go up to $85,000 a year. Thank you, Commissioner. It can go up to $85,000 a year for the eligible people that are eligible for our program. So that was the recommendation, and the reason is because it is people of higher income. Most people of extremely low income are qualifying for Medicaid. Thank you, Commissioner. So when we, again, look at the premium assistance eligibility, the individual would have to meet all the other criteria. So they have to live in the county, they have to show current income, they can't make too much money, they can't be eligible for other insurance, and they have a diagnosed chronic illness that requires specialty care outside of HCAP services. You all get to define that however you want. That is just our suggestion based on the meeting that we had with you all in November. We had a work session, and some of the feedback we received from the commission at the time helped us develop that statement, but that is up to the commission to determine. So again, our recommendation is if the monthly premiums for any of the following are less than 8%, they would not qualify for HCAP. But if it's more, then we would. And in order to, it would be very difficult for eligibility specialists to look at every single plan in the marketplace and determine if you meet that 8% rule. So we've picked the New Mexico medical insurance pool as the static amount. So we just use that amount to do the 8% rule. Again, you might be eligible to purchase insurance on the exchange, but there are so many different plans with so many different deductibles. Some of them might be more than 8%, some of them might be less than 8%, and so it would be difficult for the eligibility staff, and I don't know how we would apply this fairly across the board unless we pick one common denominator. So we're recommending using the medical insurance pool. So if you can buy insurance on the pool that's less than 8% per month, then you would not qualify for our program. But if it's more than 8%, you would qualify for our program. And then who makes that determination, especially the determination related to whatever criteria, diagnosed mental illness, requiring specialty care, whatever that criteria looks like. We talked to the medical directors and some of the leadership within the clinics, and they were not comfortable with their internal medical staff making those decisions because the benefit for the client is now you have full coverage, and they really like to keep that line between their medical providers and the patient's insurance and financial assistance. So the medical providers are treating the individual regardless of any of their financial or insurance information. So it was recommended that we contract with someone that would serve kind of as a medical director to make the decision. So the primary care provider would make the referral because the person has a diagnosed illness and requires ongoing specialty care. And then the county would contract with a medical director to make that determination, actually looking at that individual's medical file, looking at the diagnosis and the prognosis to make that determination. It's similar to what insurance companies do, so we would just be operating in the same way. But that is all up to the commission to determine, and I would like some of that, the policy pieces of that, to be outlined in the resolution. Just as a quick reminder, and I know Lucio may have additional information on this, but when we look at our FY26 budget, we budgeted just over 11 million. We have to send the 5.1 million to the state. That's the safety net care pool. The state collects that money, and then they send it back out to hospitals across the state for uncompensated care. We have $6 million in contracts. That does include $3 million for ambulance because that was budgeted when we were working with the city and providing that $3 million. That's not going to be expended for ambulance services this year. And then we also have the budgeted revenue, which is 8.5. So for this year, it looks bleak, but remember, we're not spending that $3 million on ambulance. So we're more at a break-even point. And the big changes, well, I think the big impact is that we have to send those dollars to the state. And then when there were changes to the kind of the earmark of gross receipts tax at the county level, the indigent fund each year now is less $1 million because there used to be an automatic transfer from the health fund to the indigent fund, and that is not happening anymore. So that is our expected revenue. And I know in the coming years, the overall revenue is expected to grow, but this is just a snapshot of where we are now. So, Mr. Chair, that is the completed presentation. You all also received an example of a resolution, and I have copies of it. The only difference is we took out emergency transportation. I didn't have final word from Stephen until after I sent this out. So I'm just going to hand this out. We did leave in there non-emergency transportation. We don't currently cover that, but we know that's a need. So that's something that you all can think about. So remember back here, these are the things we get to decide, and these are the things that will show up in policy and in procedure.
And Mr. Chair, Commissioners, if I can make one correction, and I apologize, Jamie. I gave Jamie the 8% threshold. It increases based on the cost of living index. So in 2025, it increased to 9.02. For 2026, it's 9.96. So I apologize because I provided that. The cost of living index.
Thank you, Ms. Michael. Commissioners, are there any questions? Commissioner Chaparro,
Thank you.
and then we'll go to Vice Chair Gomeros after.
Thank you, Mr. Chairman. Jamie, when you mentioned, and I can't remember which slide it's on, but regarding the medical director that would be contracted by the county, I work with insurance companies, and so they have like a team of doctors that goes over independent medical examinations, impairment ratings, things of that nature. Do you have someone in mind for that, or would that be like a team with a lead doctor? I guess I'm not understanding that. So if you could just delve into it a little bit more. Thank you.
Yes, Mr. Chair, Commissioner Chaparro. These are still just ideas and suggestions, so we have not started seeking someone who could serve in that role. The suggestion is just that it is not the medical provider at the clinic and obviously not county staff, that we need someone with a medical background to make this determination. But they would be making determinations based on the criteria that you all set. I do like the idea of it being a team, and there needs to be also the ability, if that person makes a determination that the providing physician doesn't agree with, that there needs to be procedures in there for that exchange of information. So our intent is, if we get direction from the board that they like this idea, then we would go back, research, and bring more detail to you all about it. But we weren't even sure if this is something you all wanted to consider.
And just, it's because I'm thinking, for example, and I'm sure Ms. Regales will make mention of this, but if we just have one medical director and we're dealing with cancer, or someone that we're dealing with an orthopedic specialist or another kind of specialist, that medical director may not have all the medical knowledge, but if we form a team, then that team can address the different chronic illnesses that we have. At least in my mind, commissioners, one medical director would probably not suffice. I like the team concept with workers' compensation and the way they do it. So they have that one medical director, and then they have others that help with that specific patient. Thank you, Mr. Chair.
Thank you, Commissioner Chaparro. Vice Chair Gamenos?
Yes, thank you. So for me, I'm good with it being the one individual or a team, because this individual or team would be looking into seeing if they would be eligible under, so we're going to be trying to, in the SOPs, make the chronic illness, how do you say it, the chronic illness for the definition of it as specific as possible, because a chronic, so we're going with, they would have to diagnose, saying, looking at their charts, whether it's considered a chronic illness that requires specialty care outside of the HCAP services, that would probably lead to premature death if not treated. So that's the criteria that they would be looking at, just to see if that person would need that specialty care outside of those services, or there would be that death. They really don't need to say, oh yes, this person has cancer, or this person has this. They're just gonna go by the diagnosis of what the primary care or whoever they got the diagnosis from. So that's what they would be looking at. For me, well, since I've been working with Jamie Michaels and staff on this resolution and the SOPs, trying to come up with the new plan 2, is what we're calling it, for the Premium Assistance Program. There's a lot of ideas that we're trying to figure out how to do this, and so I think this is a great opportunity for this workshop to get everybody's input, the commissioners. So, like I said, for me, I'm willing to take my other colleagues' brains and see what is it that they would like to come up with. There's quite a bit, to this. So for me, that's where I would like to see that, like I said, I'm okay with if it's 1, 2, 3, or 4. However way we feel much more comfortable with somebody deciding that criteria.
Commissioner, I'm sorry,
Yes,
if
go
I
ahead.
may. So if you all look at page 2 of the resolution, the draft resolution in front of you, section 5 is what Vice Chair Gameros is referring to. And obviously, the state statute is what allows us, gives us the authority to cover premium assistance and out-of-pocket costs. And based on our November work session and feedback from Commissioner Gameros, as of a few days ago, the statement was, for people diagnosed with chronic illness and need ongoing specialty care not covered by the other HCAP contracts. So that's where the commission gets to make the determination of how do we, if first you want to include premium assistance, and if you do, how do we define it by policy in the resolution?
So with that said, I do feel like we need to add language, a little bit more language to that for people diagnosed with a chronic illness and need ongoing specialty care, not covered for a fee for service, adding in there, diagnosed with a chronic illness, and needing ongoing specialty care. I want to pick on Stephen for that. He gave us a good one the other day. Some good language there with the premature death, if untreated, well, without ongoing specialty care, which could lead to premature death. That's, I think, the criteria that I would like to see in there as well.
Roberto, are you getting something else? Thank you.
I feel like
We're good, thank you. I think the more we can, my recommendation would be to start this, I think it was decided in November or agreed upon in November that we would start this as a pilot project. In my experience with pilot projects related to anything, starting more narrow and then expanding makes it easier. If we start very broad, it's really hard then to shrink, yes, to pull it back. So kind of sort of get our feet wet, jump into this with as many qualifiers like Vice Chair Camaros just provided as possible. And then, okay, it's working, we have the budget, you taken to look at data and then begin to expand if feasible.
so the other thing that I have, just by working with this and just thinking about this, I understand we have that 8%. And for me, I'm a very visual person. So everyone, I kind of give you this little packet here to look at. And so I just kind of want to go over that just so that way we can understand where I'm going to be going with this. So obviously with this pilot HCAP Premium Assistance Program, our Plan 2, right now, currently, the board had approved $200,000 in funds to use for that $50,000 per person. And currently, I don't know, has anybody used these funds currently? Does anybody know that?
Madam Chair, this is a contract between the county and Memorial Medical Center for cancer care for people that qualify for the county's program, all the other things. And we have not had any of those funds drawn down as of today.
Thank you. So with that said, what I would like to propose is that we use that as our starting point for our pilot program, as our cap for those funds, since they're already approved by the board previously. And what these funds would do is it would only cover these indigent individuals who are diagnosed with a chronic or catastrophic illness that requires ongoing specialty care that, if untreated, may cause premature death. It's only going to cover these pool of people, right? So these people, obviously, this catastrophic illness or chronic would be cancer. Maybe they have lupus and their kidneys are failing. Maybe they have ALS and they're having breathing issues. They just need more ongoing care. So it would just be this little pool of people. Right now, currently, well, this last annual report that we got from HHS stated it was like over 4,000 people that they had of encounters with the FQH, the clinics, right?
Yes, FQHC. And it was, just over 4,000 people enrolled in the program
Right.
actively.
And like about 3,500 of them had encounters for their primary care, correct? That full, it was.
The full coverage?
Yes, that's
Okay.
not minus the dental, right?
Yes.
And
Yes.
so the figures that HHS had given us way before when we were first kind of discussing all this, they were actually using that 3,500 number multiplied by, the amount of the premiums that we would be seeking, and it was coming over like 58 million or so. But, we're not going to be covering all those individuals, those 3,500 people, because they're actually being covered through the fee-for-service. They're actually, that's our Plan 1, and they will be going and getting services, continued services with these providers, these contracted providers. So we're just looking for that small little pool. That's what we're looking at actually covering. And like I said, if we had this 200,000 that was before and nobody actually has tapped into it, I figured that this would be great. And so if we go to number 2, the funds, what I'm wanting to propose is that we use these funds at a zero cost to the indigent individual. So that way the county pays all the premiums through New Mexico Insurance Pool, that we cover the out-of-pocket costs of the 5,000, which is the max on that $500 deductible, which includes that deductible. And we cover only the in-network co-pays and co-insurances. And then for the examples, I have down those discounted, the sliding fee discount that Jamie was talking about. The first one is at 25% discount, and I have the highest premium at this point, which is the 65 and plus people. And so for that, obviously, the county cost would be $28,316 for that one individual at the 300 to 399% federal poverty level range. And if we go into that second one, that one's at the 50% discount, and that's $20,540. And the following is the 75% discount, which is $12,776. Looking at this, with that 200,000, say like our in-between would be that 20,540, we could cover up to 10 people with this amount. And so I feel like this is a good start for our pilot program, just to kind of see where we can, for this year for these individuals, and see what we get. If at any time we are getting close to the 200,000, then, I'm pretty sure HHS will come to let us know. Hey, board, we are coming up to that amount. Would you like to add additional funds? I think this could give us that 6-month, hopefully, numbers or information that we need at that time. And, just for everybody, for you as well, the other pages that are attached is a 25% discount, and in case anybody wants to know what we're looking at. And we're looking at that $500 plan on all of them. And so there's the 50%, there's your 75% discount, so you can look at that information. That last page is the page without any discount. And the last page is our New Mexico Insurance Pool summary table, the benefits. And we're looking at that 500 plan again, with the $5,000 out-of-pocket annual deductible. So with that said, I would like to know what the other commissioners would like to, I want to know where do we let Jamie and the team know where we want to go? Do we want to go with what I'm proposing, or do we go with the 8% of the monthly income, meaning that everybody that would fall into this criteria, they would have to pay the 8% of their monthly income, the 8% of the premium of their monthly income. So as the calculations that Jamie gave us for that 200,000, I think it was $160 that they would have to pay for the premium.
For this scenario.
Yes,
that we
could you go
did.
back to that slide?
Yeah. Yes.
Okay, yes. So then that individual would pay $160 a month for their premiums, plus they would pay their co-pays, their co-insurances, obviously up to that $5,000. So that $5,000 would come out of their pocket. For me, I think we need to cover that, all that, giving that zero out-of-pocket cost to the individuals, only because when people are going through this type of illnesses with cancer and, any other illnesses, sometimes they can't work, or maybe, they might have to quit their jobs because of the treatments that they're receiving, the chemo, the radiation, the strain that they're going through, going through something like that. I've never been through that personally, and for those I know that I've talked to, it's a traumatic experience. And so, for them to be having to take care of finances as well, and if they had to stop working or either stop, cut hours in order to do these treatments, for me, I think at this point, these individuals are already having a rough time financially, and for them to have to pay, $5,000 for that, and then, $160 a month, I think is a hardship. And I know there's some individuals right now that are having a hardship paying even just the 20%, which I will bring up in another moment. So that's my spiel.
Thank you, Madam Vice Chair. Mr. Chaparro, or?
Thank you, Mr. Chair. I have a couple of questions. So regarding the $200,000 in funds at $50,000 per person for cancer care, the county had set that aside. And so I'm hearing, and I wasn't aware before, that no one had taken advantage of that money to date. Is that correct?
That is correct, Commissioner.
Okay, and so just so the public is aware, because I'm sure some people are listening to this, how many more months do we have in which to spend that money?
It's an annual contract, so it will end June 30th. Last year, we renewed it. So it would be, you all have the ability to renew it each year, but the current contract ends June 30th.
Okay, so next question, relatively speaking, or realistically speaking, if we were to take those $200,000 and utilize them in the way that Commissioner Gameros is suggesting, Jamie, you're the expert on this. And so if we even go down to the lowest premium, the county out-of-pocket cost, realistically speaking, will we have the time to connect to the community, therefore affording less coverage, but for more people? Do we have an idea of how many people will be taking advantage of this? I don't need an exact number, just, maybe a percentage.
So, Commissioner, that's the tricky part here. I mean, I can tell you there's over 4,000 people enrolled in the program. I can tell you how many of them most likely have Medicare, so they don't need full coverage, but I cannot tell you how many of them have a diagnosed chronic illness. So it's really difficult to determine the number of people we may serve. It's also when we look at the bigger context of the time, the number of people that are becoming uninsured is growing. And we know that with our program, we're only seeing a portion of people who are uninsured. So now if there were to be this new opportunity for premium assistance, I don't know if more people would begin to engage in healthcare. So I hate to say this, but your guess is as good as mine. That's why I like the idea of creating some parameters for a pilot project that will allow us to learn more, collect more data. Also keep in mind that the other additional expense in addition to the $200,000, and because we're not covering ambulance, the money exists also, but we would need a contract with a medical director or a group of medical providers to help us with this. And it may be a small amount because they may only have to review 2 or 3 cases. It may be a larger amount because maybe there's 30 or 40. Again, we don't know. And also keep in mind that it's going to take a while to ramp up. So even if we are able to approve this resolution at the second meeting in February, it's going to take us a while to ramp up an agreement with the New Mexico Medical Insurance Pool, the procedures for purchasing vouchers and giving people vouchers. So we're still talking about a ramp-up time, but if we hold to the 200,000, then it won't change our budget for next year either. I just didn't want to give you the idea that we would begin spending that 200,000 immediately on this, this pilot project.
So another question, if I may. Regarding this pilot program, when do you anticipate it commencing?
I would say we need at least 4-month startup from the time that the resolution is passed. So we have clear, like we're building on set policy.
So we're looking at perhaps a startup date of July 1st?
That would be very reasonable, yes.
Good. All right, thank you. I'm sure I'll think of other
Thank you.
questions. Thank you.
And really what I hope to leave today is some direction on sections 2 through 5 of the resolution. So section 2 is the payer of last resort section. If the group is there's consensus around us remaining the payer of last resort, and then do we want to stay at the constant 8% of their monthly income, or do we want to utilize the source that Deb was talking about where it would change each year? So instead of saying 8%, we say as according to the cost of living increases. So I'd like to get some direction on sections 2 through 5 before we leave today. Number 3 is a fairly easy one if we want to start there. Okay, so
But-
number
but-
3.
but Before you
sorry,
get into
yes.
the sections, I have several questions.
Oh, yes, sorry.
Thank you. Number one, I think when you talked, I know you indicated in terms of the audit that occurred when we were trying to identify the issues with potential programs. But to the best of my knowledge, I think we're like the only county in New Mexico that requires or had been relying on a federal tax return as proof of insurance. Many other counties and municipalities, or I should say not municipalities, but counties have been using other forms of proof of income. And so, and I know you said that we can use that, but we have chosen that because of the audit. And so just wondering why that is, and why do we have that barrier, especially knowing the community that we're serving. And I think I'm particularly sensitive to it right now because I think there's a lot of individuals in our community that are going to be very reserved or even will shy away from providing some of this because they may not have a tax return, or they may not even make enough money to have a tax return.
So let me clarify that, Commissioner. In the SOPs, so we do say you're required to show us your tax return unless you make less than the threshold and you're not required by the IRS to submit a tax return because you don't make enough money. In those cases, then we do take the monthly income evidence and multiply that out for your annual income. And just to clarify, there are several other counties that do require tax returns or other similar documents. We're probably one of the more broad counties in allowing as many people to qualify as possible, but there is nothing that says you have to use the annual tax return. At the time, the commission felt that was the most accurate and fraud-proof way of documenting maximum income, but there's a whole list of documents that prove monthly income. So, you could also take any of those and make it, those are eligible documents to show annual income as well. That would be, again, I didn't want to change what a commission had put in place previously, but you all can.
I understand. Okay, so that might be something, I think in my mind, like I said, I really do have some concerns, like I said, just between where some of the people in our community are going to be able to provide that or not have that return. So I think I'd like for us to maybe take a look at that piece of it, or opening it up to allow for other, like you're saying, other forms, and if there's some concerns, like, I think like you had noted, that they're filling them out themselves, like by hand, maybe, we put some, define where we're at on that, and I can understand some piece of that. I think, like I said, using the annual tax return was one of the concerns I had. You
Can I
mentioned-
ask, I'm sorry, Commissioner, so if we were to use the documents listed under current income, does that make more sense to you? So it could be your tax return or any of those other documents? Okay, I'm seeing a lot of nodding, so
Yes.
that's good.
Yes, so
All right.
with that said, Mr. Chairman, if I could just pop in. I was researching Sandoval County Health, and with them, they do have that the annual tax return income is used only for self-employed individuals, but then they also have an area that says that if a person is unemployed or is a cash-based person, then there's a voucher that they actually have, that these people get notarized, an affidavit voucher that Sandoval County uses as well. But they use, they can use their bank statements, and they don't, like I said, the only time they have the annual tax return is for those self-employed people, to show proof of the Schedule C and all that, so.
Okay, I mean, I
In
don't-
in the past, we were taking, I would write on a piece of paper that you worked in my restaurant, that you cleaned my home, that you babysat for my children, and we were taking those pieces of paper. And so I can see why people in the public were concerned that could, there was more of a probability of fraud if we were doing that. So the whole list of documents under current income seems like it's a nice balance between where we were and where we are now.
So I think I think like Vice Chair Gameros is saying, if we were to have something that's notarized or something of that nature, does it change that piece of it? Like, I guess understanding how, I guess I'd have to get a little more educated on the way that, like she's indicating that Sandoval County may be using some of those notarized statements, but just trying to understand where that might, trying to strike that balance of, trying not to ensure that we're not opening ourselves up for potential fraud or abuse or any of that nature. I mean, this is not, I don't think like somebody's going to be.
It's not a highly coveted,
Well, I think they're not.
benefit,
We're not. I don't think based off of I think how we define this, right? I know we're not going to be providing direct reimbursement to people. We're going to be helping them purchase their health insurance. So I think it's like that's why I say I think it's not like a direct where somebody can abuse the funds, like where they're going to take it and go buy I don't know, go crazy with this money. But I think I know we don't want to, we want to make sure that we are covering the people that are needing these services and trying to make sure that we're applying our money in the best way that we can.
Right.
I'm just trying, like I said, I think trying to find that balance and understand though that some of our residents are limited or may not still have some of these documents. I don't know. I think that's one of the things that I see. I don't know. In my mind, I think initially looking at the list, I think it's pretty extensive. I just, like I said, I think that's something maybe we have some discussion. I'd love to get a little more educated on.
so Commissioner, I can ask Norberto, because he meets with the other county healthcare programs monthly. He can take a look at this list in comparison to the other counties' evidence, and the only difference, so for current income, we take 1 month pay stub, but to document annual income, we might want 3 months, and then we would use that 3 months to calculate 12. So that might be the only difference, because a lot of, there are a lot of people that have different incomes over the 12 months in a year. And that was another reason why the tax return was preferred previously.
Two other questions. One, I know we were talking on SOPs. I don't know, not wanting to, and understanding the time to take to implement and ramp up. Just wondering if there's a way in which we have SOPs that get approved or at least ready to go from when we sign if we know the direction the resolution is going for the program and that we believe it'll be approved, would it make sense to have the SOPs ready together, even if that means maybe slightly delaying the resolution? I mean, I guess what I'm trying to say is my concern is we go through the resolution, we approve it, but if we're we want to make sure that there's follow through for SOPs that are updated accordingly. I just not sure if doing them at the same time where we know the SOPs are ready, then we approve the resolution, that makes more sense, or if that delays because we're delaying the signing of or the approval of a resolution, that would delay other downstream items.
Mr. Chair, I would take direction from the county manager, but my preference would be to bring the resolution back as soon as possible, because that's the foundation for all of our procedures. And then just to stay consistent, I would prefer to bring the SOPs back as an informative document versus something that is approved by the board, because I think it's going to go through some changes. And it can be an administrative burden to bring back procedures. And usually procedures are within the purview of staff and policy in the purview of the commission. So to get things moving quicker, I would like the commission to approve the resolution that sets policy for all of these things and then come back. I think we could come back in early March with the probably most current draft of an SOP, again, knowing that that's a document that is going to continue to evolve. Yes, absolutely. And we have started working on the SOPs, so I'm happy to share that with you all right now so you can see where we are. But again, as we make more policy decisions, the SOPs will evolve. But I can show you what it looks like now.
Do we have existing SOPs?
We do. We have the existing SOPs, and then we have this new draft that we've been working on.
Okay, and so I don't think there's like significant changes here. I mean, there's some that obviously will come, but I guess I don't understand where if we're not writing SOPs from scratch, we're just going to be revising them to match. I guess I'm missing where there's going to be a significant amount of work to get an SOP to match some of these changes that we're asking for.
Mr. Chair, Commissioners, we were given a new format that we were requested to revise and revamp the SOP in total. So it's a little bit more than just redlining the existing SOP, but I think they've got a good start to the draft, but that's why it's taking a little longer than it otherwise would. We were asked to basically revamp it in total.
And the expansion into premium assistance is a brand-new component that there's never been any kind of procedures or SOPs related to that. And that's where I see the most change over the 6 months.
And I think part of the reason why I'm curious is I think I want to understand the mechanics of this, because if we're going to approve the policy to go forward with it, needing to understand how it's going to be executed for me and where I'm, at least my perspective is very key, because my concern is that if we have $200,000 that was set aside as part of the annual budget, and now we're 7 months into this fiscal year and none of it's been used, it makes me very concerned that I think we have amazing programs here at the county. The things that I've observed in my time is that we have a hard time connecting people with those programs. And so if we're telling me that we set aside $200,000 and not one person has been able to take advantage of it, then something I feel is broken there.
Well, Commissioner, if you remember when we had Memorial Medical Center come and present on their cancer care, they were estimating that 1% of the folks that seek cancer care there do not have access to any other insurance. So they were not, the data was not demonstrating that there was going to be a lot of folks in that circumstance. So it's playing out the way that the Cancer Center folks had expected it to play out. And we have not gone out and advertised that, hey, the county is now covering cancer care. We have helped make the referral processes easier between the FQHCs and Memorial Medical Centers. So if someone is diagnosed at the primary care clinic, they have an easier pathway to connect with the hospital, but we're still not seeing people that completely qualify, that qualify for this program, that are completely uninsured, needing to draw down those dollars. And we're continuing to work on those referral processes, like the state has the breast and cervical cancer screening and diagnosis program, but there's then this like cliff that they fall off of and can't get connected to treatment. So we see our role as helping create those pathways to make it easier for those folks to come to Memorial to get care. And it would be really nice if our program could cover the cost of that care when needed. But we have not gone out and advertised, but we have never done that with the county's healthcare assistance program.
But I think even when we had the discussion with Memorial, they didn't share data really with us. Maybe I'm wrong, but I don't know, commissioners, did Memorial share information with us? I think that's been our biggest issue with Memorial, is really been trying to get that data. So I guess I don't have, I guess I'm having a failure of trust with Memorial and what they're doing and their processes. So like I said, I would hope in my mind, and not because I don't support this at all, Vice Chair Gameros, I want to make sure that we have a chance to review what we're going to do and execute, because I want to make sure that we are not putting Memorial Medical Center in the driver's seat of this county program. I do not want them in control of it. I do not trust them, and I know maybe it's not, we're trying to build a new relationship with them, but even under the leadership of Mr. Knox and others, I do not have that faith in them. And I apologize for kind of putting that out there, but it bothers me. And one last question, and this is probably for Lucio. Do we have any projections of what we're anticipating from GRT, from Project Jupiter to be funding, or at least going into the indigent healthcare program, and what that's going to be looking at for the budget over the next couple of years?
Yes, sir. Commissioners, the early projection we have over the construction period is around 28 million. We will revamp those projections as we get more information in the next few months, but we're expecting around 28 million over the course of those 3 years.
So I'm sorry, Lucio, so the 8.5 million will turn into 28 million?
So that will be over a 3-year period. So we're still going to get our regular 1/8 we're anticipating with our GRT growth from normal operations, but just for the construction, it would be 20. So if construction happens to be split up evenly over 3 years, that would come out to 9 million a year or so.
In addition to the 8.5?
Correct.
So we have the potential to double our annual revenue for this program?
Correct.
Okay, I just want to make sure I understand. Thank you.
Okay.
And Commissioner Sanchez, if we are helping people purchase insurance on the exchange, they can seek cancer care
Anywhere.
anywhere. They won't be restricted to Memorial.
No,
And
I
I have
think it's
called
the-
around, there are places that accept the pool in New Mexico.
Yeah,
I mean, in Las Cruces.
And I'll tell you, I apologize for a little bit of pent-up frustration with MMC coming out. But I think my concern, my concern is around if they happen to be local and they are diagnosed, and it doesn't have to be, I don't think we're saying it has to be diagnosed at MMC, but I think because they are one of the larger providers here, especially in the city of Las Cruces, that my concern is that if they go and get diagnosed there, and then they don't, like I said, it's that note, if we let them be able to say or connect people and they don't want to do that, or they have no initiative to do that, then I think we don't get those people that are needing that service with it. That's my concern.
No, and the referral and the initial diagnosis usually comes from the primary care doctor. And that's where we have the really good relationships with the FQHCs and with the state's BCC program.
Yep, and I appreciate so much, like I said, the FQHCs and everything they've done and working with the county. So I think overall, I think if I guess going back and just my last comment is going to be to overall on the cost of the program. I like the idea of using the initial 200,000. I think as we start getting some of the monies in, maybe we expand that a little bit more. But I think as we're trying to get data on, is this something that there are a lot of people out there that need this program, or there are not enough, a lot. But I think maybe doing the pilot program will give us an opportunity to start collecting that data to see the what and the how, and being able to see how we move forward. So
Yeah, it's something we've never offered, so we really don't know how many people can take advantage of it.
Chair, Board, I hear a sense of urgency from all of you, so I guess I'll look to the team. What is a realistic timeframe to knock out, tie the SOPs in the way we've discussed here today? Are we talking the next meeting, a week away, or the end of the month? What is realistic?
So if we have the resolution set and I get answers or kind of direction on these sections, I think we'll have a operational version by the beginning of March of the SOPs. Does that? Yeah, by the beginning of March. So I can bring it back at a work session or at a commission meeting. And we can either do it as an informational or as kind of an attachment to the resolution, if you want to see them both at the same time.
Mr. Chairman.
Vice Chair Gomez?
Go ahead, please.
Oh, I just wanted to touch on what you had said on your second question of the SOPs.
Yes.
And so at the time when I was looking at the SOPs, well, actually, the resolution is what was brought to me. And I saw that the changes were being made on there. And from what it looked like, the resolution, there was like policy and procedure in there. So I didn't realize at the time that they actually had SOPs. And so, because that's what I was hoping that I was going to see when I was talking with them. So I did provide them with the template. And that's the revamp that they're talking about.
And
like I
that
said,
was
I wasn't
helpful.
aware.
And that was helpful because we did have the resolution that, like you said, mixed SOPs and procedures, and then we had the contract, and then, we had sections of things, but what you provided is helpful because it's going to be an overarching one document for all of this. So I
Yeah,
think it's a good exercise and it's a good product that we're going to have.
So, and I do agree that we should be approving the SOPs as well and any type of changes because this is a pilot program, but I think that the board really needs to be involved in these procedures, right? As how they're going to be working this and have that knowledge. Because if we don't, let's just say from now, 10 years from now, right? There's other board members on here. Maybe there's other staff that's doing this. That knowledge is going to be gone, right? And then they're going to be following what we have on documents. And so I feel that we do need to be on top of these procedures until we figure it out, because it is changing, especially this premium assistance. Like Jamie asked, are we the payer of the last resort? Meaning that, we're going to pay, like, I'll give you an example of that Medicare. We have in here that if you have Medicare, that you won't be able to participate in this premium program. There is an individual that, he's an elderly gentleman that has cancer, and he only has Medicare, and so now he has to pay the 20%. And obviously, he's going to chemo, he's whatever radiation, whatever treatments that he's doing, and his first bill was $960 some. And his daughter had already stated that she can't pay that, the family can't pay that $960 some. And so what I'm kind of noticing talking to these individuals, thanks to Yoli, is they're wanting to give up on their treatment because they feel like they're seeing this bill and it's becoming a burden. So how are these individuals going to be able to decide, I'm going to heal, whereas the stress on trying to cover this is there and they can't? How can an individual actually heal? They're not going to heal. And what they will do, a lot of them, there's already one that said, I'm not going to do any treatment at all, just let me die. So I think we need to stop that process from happening and try to help individuals the way we can. I think this payer of last resort, I don't know, I just think that we shouldn't have that there. I think we need to come up with a different criteria, helping certain individuals out. I don't see it in Sandoval County. They don't have anything that matches, that says payer of last resort. So I do think that maybe, we do need to look at these other counties and see how their programs are, what's the wording that they have. So with that said, also, I do have some questions here from Yoli Diaz. And so I did want to share some of them, but, as we were talking about the referral, there was an individual where her mother didn't get a referral at all. And so with that, with these procedures, the SOP, that's where we're having to work with MMC. So like if MMC is actually, this individual went in and they did some diagnostic work on them and they found the cancer there at the hospital, then we do have to be working with the hospital there to say, hey, there has to be some type of procedure where wherever these individuals go, that they are either being, having the screenings happening to see whether they fall into the program, whether, we have staff here that they're able to call or come and see if they can do the eligibility screening here, because maybe the individual got diagnosed at night and, they treated them enough to release them and now they release them. And they didn't get to do the screening there. So these are a lot of things that we have to look into within the SOPs. So I do agree that we do have to be approving, just like we just approved the SOPs for HR, right? So why aren't we approving these?
I think we're not approving, I don't think the SOPs for
Well,
HR.
not this
but-
one.
Well, but no, I don't think, I think that's where, I agree. Like I said, I want to make sure that we're educated. I just think, like I said, I don't think we've approved the SOPs as a board, but I just want to make sure that they're all ready to go, that to me, it's to be part of the package. While we approve just the resolution, I want to make sure those SOPs are ready. And I don't know, like I said, I'm open how we do it, whether.
Yeah. And I don't have a preference either. I just know that if I don't get some direction on policy, that I can't even start with procedure. So I was originally going to walk away thinking payer of last resort, there was consensus, but now I'm thinking I need to bring more information back to you all before you're ready to make a decision about that. I'm trying to take these just one at a time so we get clear direction and bring back the information that is going to be helpful for you all. So we will look into Sandoval County and what they do for payer of last resort. Because as far as I know, counties don't cover if you have access to other insurance, but I could be wrong, so we will research that.
Commissioner Chaparro?
Thank you. And just to follow up, Mr. Chairman, on what you said regarding MMC, as Commissioner Shelder Hernandez recalls, and you, Mr. Chairman, and I were on the commission when MMC came and did a presentation of sorts to this commission and told us that they would be following up and coming back and presenting again, and that didn't happen. But if anyone from MMC is watching, and I'm hoping you are, I challenge you to come and chat with us, help us with working through some of this resolution and SOPs, because we're going to be connected. And we must be able to provide adequate health care to our constituents. And if we're lacking communication, and if we're lacking community connections, then none of this is going to work. So MMC, I am willing to sit and chat with you. I'm sure all of these commissioners are willing to sit and chat with you. I'm certain that this wonderful staff is willing to sit and chat with you so that we can provide better health care to our constituents as they deserve. So please come talk to us. Thank you, Mr. Chair.
No, Mr. Chair, may I jump in real fast? Trying to help Jamie out a little bit. I know you're looking for direction. Perhaps we can have an internal staff meeting and avoid quorum, but invite two of you to see who's interested. If you want to make yourselves available for that meeting. So that way, when we sit back again, we can even do a staff update in the next board meeting to talk through the progress that's been made. And maybe even the meeting at the end of the month that Ms. Weir will be leading, perhaps is another opportunity as well. Just trying to get some momentum going here.
Yeah, I'm open. I know we wanted to go through, Jamie, you wanted to go through section 2 to 5, but I think kind of given like what we're, the direction, I think if you're open to it, I know Vice Chair Cameros, I know this is something you've been championing. Are you mean, would we be open to maybe what Scott has been suggesting, or how would you like to proceed? I only say this because I don't want to derail this at all. I want to make sure, like I said, I think for me, myself personally, I want to make sure that we have the best. I'm excited for the change. I want to make sure that we have it rolled out so our residents can benefit from it. But I don't want to appear like I'm causing delays is going to jeopardize it from not happening. So I wanted to get your, like I said, because I know this is something you've been working on. So I just want to get your thoughts.
So for me, I mean, if the commission is comfortable with going through each section and stating, okay, yes, do we want payer of last resort in section 2? I think that's what you're asking, right? Do we go along with that, right? Or do we go with what I suggest? So there's those two options. We could do that, but if the commission doesn't feel comfortable, and maybe, as the manager stated, getting two of us at a time and then going through that and then going over that information. I just would hope, because, we're going to have different opinions, right? And we're going to have different thoughts. So if two of us are together in one and we're throwing that out, I'm hoping that they come down and say, okay, these two commissioners, this is what they're looking at, and these other two commissioners, this is what they're looking at. And then giving us that information, providing us that information, because, like I said, if you're not in the conversation, you're not in the loop, right? And so I want you guys to be in the loop.
I mean, we could do it. I mean, if we're open to taking a little bit of time now, we can go through and just kind of have at least a conversation on these sections and at least get a little bit more direction if we need. I'm good with that. If you want to just dive in and then, if we get direction there and then we can fine tune any other thing that we need later on. But I do appreciate, I think, having us all in the conversation so that way we're able to all give some input here.
Thank you, Commissioner. And even if we don't get to consensus today, at least you know where to begin thinking and providing feedback, whether the feedback is as our county manager described, or just send us an email. So section 2 is putting in the resolution, payer of last resort, making that clear. Again, individuals who are eligible for other coverage. The one exception is if you're eligible, for example, if you're eligible for Medicare, but your coverage, like Medicare doesn't cover dental, so it's not just eligible for other coverage, it's eligible for other coverage that covers the same type of service. So that's in there. And then now the 8%, you all can change the 8% to being whatever the current rate is. So those are the two questions for Section 2. Section 3, I think, is a little easier. And again, we're creating a lot of conversation about something that has very little impact. When we look at these out-of-county claims, because of Medicaid expansion, we've been paying, in some years, $0 for these other claims. So we're really not talking, most people have Medicaid coverage, but we just want to make sure that if we do happen to get a claim from a hospital that's outside of New Mexico and we pay it, that we have a document that we point to show why we paid it. And so we're asking just to clarify this as out-of-state hospitals, and the reason we say out-of-state is because all of the hospitals in New Mexico receive money from the state for uncompensated care. So these dollars, that safety net care pool dollars that we send to the state, those get sent back to New Mexico hospitals to compensate them for uncompensated care. So we're saying let's not pay claims on top of that, but if it's a hospital in Texas, for example, they don't get that money from the state, so we may have to pay an out-of-state claim for that one. The cap of 50,000, again, was just in the previous resolution and has been historically in there. We never come close to it. The 31.1% of current Medicaid rate, I have no idea where that came from, but it is an exceptional deal. And so we, I feel bad even putting it out there because we don't want that to change. It's the lowest rate that anybody could possibly pay to reimburse those claims. Number 4, and I might rename number 4 just because fee-for-service has like health insurance definitions around it. It might be more accurate to say per encounter. So when we contract for primary care, dental, and all of those services, we usually pay a per encounter rate. But I want to make sure that the board determines what type of care we are covering. So back to the primary, dental, behavioral health, end of life. The emergency has been stricken, emergency transportation, and if you all choose to leave in non-emergency transportation, again, that is oftentimes a need. It doesn't do much good. If we'll cover your visit to your primary care doctor if you can't get to your primary care doctor. And I think the costs around that can be manageable, not exorbitant costs for non-emergency transportation. And then number 5 is, do we want to include health premium assistance? Do we want to include premium and other out-of-pocket costs? We will make the change that without the care, without the specialty care, it could lead to premature death. But if there's anything else that you would like to see in Section 5 around eligibility, not process, again, just who we're going to cover, and premium assistance or premium assistance and other out-of-pocket costs. So for those sections, that's the direction that we're looking for to be able to, I think, create a very strong policy statement in this resolution.
Mr. Chair, if I may.
Yes, please, Commissioner Chaparro.
Thank you. Jamie, I like everything the way it is, quite frankly. Section 2 is acceptable to me. Section 3 is very acceptable to me. We're a border city. A lot of people do travel to El Paso for treatment. I'm very much aware. My father was one of them. Section 4, I like the per encounter visit instead of fee for service.
Yes.
I think it defines things better.
Yeah.
And number 5, I'm fine with adding the verbiage that Vice Chair Gometos had suggested to try to prevent premature death. So I'm cool with the rest of it, Commissioners. Thank you.
Thank you, Commissioner Chaparro.
Mr. Chairman?
Yes, Vice Chair.
So for me, Section 2, I feel like I want to strike out payer of last resort. So also, I have a question just to clarify for me, Jamie. That last sentence, well, it's a running sentence. It says here, oh, let me see here. Eligible for any form of health coverage. Okay. Eligible for eligible for any other form of health coverage shall not be deemed eligible for assistance under the county's assistance programs for the same type of care. Or if the monthly cost of the available coverage is less than 8% of their monthly income. That's the example that you gave us of the premium. Are we talking about the premium there?
That's not talking about the premium, that's talking about how accessible is coverage. Again, I might be able to go out and purchase insurance on the exchange, so I'm eligible for other coverage, but if that coverage is going to be an exorbitant cost, then is it really accessible to me? So that's why we put, if the coverage that is available to you is more than 8% of your monthly income, we're considering you uninsured because it's not really insurance if it's not affordable. And the test for affordability that we proposed is 8% of your monthly income.
Okay, so the coverage for them is more than 8%, right? Okay. And section 3, let's see.
I'm sorry, Commissioner, let
sorry,
me
go ahead.
just back up a little bit. So just by removing payer of last resort, but keeping in the individuals shall be ineligible for assistance under the county's healthcare assistance program if they are eligible for any other form of coverage. So you still want us to keep that in and still look to see if they have employer-based, TRICARE, Medicaid, Medicare. Is that correct? Okay.
Because I do want to bring, I do want to try to see about those individuals that are having that are underinsured, right? Because right now, the way this is reading, it's only reading for uninsured, uninsured people, but not underinsured people.
The only reference to underinsured people is coverage for the same type of care. And the example is Medicare, the basic Medicare does not cover dental services, and it does not cover residential hospice services. There may be other things that it doesn't cover, but that's for the same type of care is the underinsured population, but it would not, we wouldn't consider other out-of-pocket costs there. That's just, take that one criteria on its own. Is this person eligible for any other insurance? And we have to be able to answer yes or no with that.
Okay, with that, okay. Well, I think if we can actually define it, the other coverages, especially with the uninsured, just defining it a little bit more. That's what I would like to see.
And particularly around Medicare.
Medicare.
So
The
we would
underinsured.
say the individual, da-da-da-da-da, and then we would have an exception, except when Medicare out-of-pocket costs are greater than some amount. Is that kind of what you're thinking?
I mean, well, if we're going with I understand this 8% thing, right? But as Deb said, that it's going up every year. So.
And you all can choose to stick with 8%, or you can choose to go with the source
9.96.
that goes up every year, yes. And so you can, instead of saying 8%, we would reference, just like for the max income, we don't say 85,000, we say as based on the current U.S. Department of Commerce, blah, blah, blah.
So okay, so then we would be looking at the underinsured, for example, if their monthly cost available to them is, well, okay, if they're, I'm sorry.
I know, these are, because sometimes they sound like a double negative in the way it's written.
Yes.
So we do want to cover people when their insurance that's available to them is too expensive. And right now, our definition of too expensive is more than 8%.
Okay, so let's say they're, well, they have Medicare and they're covered, but like I said, the 20%. So how do we determine that? So we're using that 8% on the cost? I mean, it's not necessarily the premium, right?
Correct, that's just, does it cost them, how much does it cost them to have the coverage? So there would have to be more language in there creating an exception for people with Medicare. And we would say something like, except for people who have Medicare
Only.
only, and I was trying to think of Part A, the basic Medicare. The county's program may cover costs that exceed some amount. I mean, that's, at this moment, that's the only thing I can think of. But if you, like, if that's enough direction and we can do what the county manager says, then give us time to process that and come back with some options.
Yes, if we can go ahead and do that. So we can kind of get a, because unfortunately, we just don't have the data, and then, like I said, we're just only thinking of the individuals that have these chronic illnesses. Right. And so with that,
But that's the type of direction that I'm looking for, even if it's, we're not real comfortable with what's here, but bring us back something that meets these different criteria. So what you're telling me about Medicare is enough direction for me to bring back more information.
okay, thank you for that. And so are we ready to go to section 3? Okay. So I'm fine. I mean, I feel like we do need to still continue to pay out-of-state hospital coverage. The last sentence, well, those claims that comply with the indigent criteria shall be paid up to the cumulative cap of $50,000 per person. So is that going to change that language? Because now we're using that money, that the $50,000 per person, which is the $200,000 for, well, what I'm proposing.
It wouldn't affect this because this is only for out-of-state hospital claims.
So this is something that's separate from that 200,000?
Correct.
Okay,
Correct.
good to know.
Yes.
I thought it was the same.
We
Okay.
used the same dollar amount, but they're
Okay.
for two different criteria.
Okay, all right. Well, thank you for that information. And then, can you just, I guess, kind of like, I know we kind of talked about this the last time we had the discussion, but if you can just refresh my memory, where it says like the per fiscal year, what do you mean by that? Per fiscal year at 36.1% of the current New Mexico Medicaid rate, and why are we going with that? Oh,
So,
I know, just-
Commissioner, honestly, we're going with that, and that's one of the answers because that's the way we've always done it. I've never found anything in the paperwork historically from 20 years ago, but it is a steal of a deal, and so I don't want to go back to any of the out-of-state hospitals and try to negotiate anything. We've been able to offer them this amount, and they've said, thank you very much, because it's better than nothing
So
for
this is the
them.
rate that they're paying according to that
This is
bill?
what we're paying them. So they send us a bill
they're
for
charging
my
us.
hospital stay at Lubbock Burn Center, and they accept, and this 36.1 is strange. Again, I don't know where it came from, but this is one of
what we're
those,
being
if it's not
charged.
broken, don't fix it. We say we'll give you 36.1% because that's what we're allowed. So being able to say that's what we're allowed, they go, okay, we'll take it.
Okay,
And if I can just make just a quick comment, and I'm just wondering, I think as we do this, so just kind of with the numbers that I know Vice Chair Gamero shared, and I know this is like a cap, cumulative cap per person, and I'm not necessarily against that. I think one of the things that I'm wondering is, we did that with the intention that we were going to have to pay, for a person completely, or at least that was the max. but given kind of what, if we're looking at being able to provide them with the healthcare assistance, and so say even it's the most expensive at 28,000 for the fiscal year, all they, or I don't know if it, I guess it wouldn't be fiscal year, it'd be the annual, the
So let me-
calendar.
Just real quick, this cap is only for out-of-state claims.
Oh, okay,
This
got it,
cap
got it.
doesn't
Yeah,
have
yeah, yeah, yeah.
anything to do with anything
10-4.
else. So take
But-
these sections, like that's just for that. We haven't set an individual cap for premium assistance or out-of-pocket. The recommendation is to set an overall cap for the budget, the 200,000.
And that's regardless of, and I'm just trying to
Yeah.
think, like I said, if people were to qualify for this, for the assistance program, then they wouldn't even if they go out of state, they probably wouldn't even reach that because the insurance would cover.
Yes, we would never be paying that claim, correct. Mhm. And really, Annabelle, in the last 2 years, have we paid any out-of-state claims? Okay.
No,
We have. And about 20,000 kind of dollar, okay. So again, because of Medicaid expansion, this cost to the county almost became nothing. But it's nice to have it in here, because I like to be able to say, we're only allowed to pay this much.
okay. Okay, thank you for that. And section 4, I'm okay with the way it is, adding in the per encounter service, as Commissioner Chaparro stated.
And are you all okay with primary, dental, behavioral health, end of life, limited ortho and physical therapy, and non-emergency transportation?
Yes, I am.
Okay.
If I may interrupt, Mr. Chair, real quick. Thank you. So now that I'm thinking of non-emergency transportation, are we talking like that dial-a-ride?
Something like that, or Uber Health. And it is non-emergency transportation related to healthcare needs. So it's not to the grocery store, it's not to, it's just to, we'll define it in the contract where it is to access your doctor's appointments.
Thank you.
Yes, thank you. And then the last section, I think the biggest question is premium assistance or premium assistance and out-of-pocket costs.
So you know where I stand with that.
Yep.
I stand with premium assistance and out-of-pocket costs, but with the other rest of the commissioners, I'd like to know them to give you their input on that.
I think if we, well, I should say other commissioners if you want to. Sorry, I didn't mean sorry, Commissioner Chaparro, please.
It's okay. Mr. Chairman, Jamie, when we're talking about out-of-pocket costs, I mean, to have to define that, to me, is going to be difficult in my mind, and it may not, but I'm thinking that it may be difficult. Can you help me with that?
So the best way, and again, if you want us to explore more, this is the direction I need, and we can go do that. Right now, if you look at what Commissioner Camaros gave you and that summary of benefits, though that outlines the out-of-pocket costs for the New Mexico medical insurance pool, which is all we would be contracting with. So everything in the premium assistance and out-of-pocket costs, everything in this expansion would be related to the New Mexico medical insurance pool. So that gives you the example of out-of-pocket costs, and the scenarios that the commissioner worked out are examples of covering both the premium and the out-of-pocket costs.
So if you go to, jump in that first page that I gave you, the pilot HCAP premium assistance program, which is this one. Yes. So number 2, B, it's out-of-pocket costs of $5,000. That includes the deductible. And C, in-network co-pays and co-insurances.
So we could hypothetically define the out-of-pocket
Yes.
there is specifically the out-of-pocket max as per the, sorry, if you can, what,
New Mexico Medical Insurance Pool. Call it the pool,
the pool.
the pool.
So we can define it, so that way, so that it's very defined, it's just, because I know the way they define it is you have your, obviously you pay your premiums, you have your deductible, but then it'll have a max, an annual out-of-pocket max defined for the coverage. So I think if you define it as that, then, it won't be taken, it has to be specific to the health, it has to be a health coverage that would be associated with the insurance.
So if you look at this scenario, we would be paying the $160 a month for the premium, and then we can pay up to an amount for out-of-pocket costs. That's one way of defining this. But I just need the resolution to say premium and out-of-pocket costs. Because if it just says premiums, then the procedures that we bring to you won't include out-of-pocket. If there's a desire to include the out-of-pocket, then we can bring some options to you about how to design that and what kind of limits or parameters to put around that. But we won't bring it to you if you don't say, yeah, we're looking at out-of-pocket costs as well as premiums.
I'd like to see the out-of-pocket cost verbiage, the language as well. I mean, we're not voting on it today, we're just
Yeah.
exploring it. And so if we can, Jamie, if you and your staff could please look into that for us.
I think
think
Commissioner
that's a good
Camaro's
idea.
set us up to do that really well. So yes, that would be very, very easy to do. So all of that information is extremely helpful. Roberto, is there any clarification that you need based on the discussion that we've heard so far?
Not right now. I took notes and I think we're.
Okay.
I think one of the, I think I'd be open to, with it being like a pilot program to, I think the two things that play in my mind are, I think I'd be open to looking at doing the coverage to allow for the full 100%, paying for the premium and the out-of-pocket max if they qualify. But I think the other part of it, I think part of the reason why I think I'm open to it is I'm kind of, if we're looking at potential additional funding coming in next year from the GRT, I think it gives us an opportunity to, like I said, do it at least as a pilot project to see, and we can provide a cap, I think, too, to see, if we reach, number one, if we reach the cap, then we can evaluate, okay, do we need to increase it? Do we need to change some of the coverage? I think it gives us that point in which to have some max level that then we can determine our next steps. But I think having some of the additional funding come in lets us try something new and see how it works. And if it doesn't work, we can come back, make changes, or scrap it altogether. But I think I'd be curious to try it at least for a year this way and see what data comes in and kind of lights our way for this.
Absolutely. This is so new. We don't know what we don't know, and we don't know what the need is. But I think we all are in agreement that there is a need.
Yeah. I think I just, this is my hope, and was as we kind of go through and start exploring some of these things, I think let's, we've always been very conservative and I think very good with how we're trying to spread the money as best we can to serve the community. Not that I want to go spend it all in one place, but I think we have some opportunity to be able to take try some different things that we've never done in the past because we just haven't had those additional funds to try something different.
Absolutely. And the other thing to remember when we talk about budget, this 3 million, because I'm going to take out the 3 million from ambulance, the 3 million that goes out to the contractors for the primary care, dental, blah, blah, blah. A lot of those contractors run out of money long before the end of the year, and we're getting ready to go back out to RFP. So I'm expecting that the cost for this is going to increase as well. And again, the commission has full authority to allocate the dollars, but we also have to consider these contracts as well, because I don't want to lose sight of the more upstream healthcare that we're providing access to as well. So thank you, commissioners.
Thank you, Jamie.
Okay, Deb,
I think-
anything
I don't know
else?
if Any other last? Okay.
Are we good?
Thank you for the working through that with us, Jamie, and the conversation, commissioners kind of getting through that. I know it was a little longer than maybe may have thought or anticipated, but I appreciate having you all in the same room and discussing it with us. So. All right.
Okay, thank you.
Okay, then second item we have is discussion on Senate Bill 3. Lucio?
All right, good morning, Mr. Chair, Commissioners, Lucille Trell, Interim Deputy County Manager. This item was really just to update you on Senate Bill 3, where it's at. And so the title is Commitment Procedure Changes and Definitions Update. So this presentation will be relatively quick. And so just to summarize it, the bill changes how New Mexico defines harm to self and harm to others in mental health commitment laws and updates the legal standards used to determine when someone can be involuntarily committed for mental health treatment or ordered to receive assisted outpatient treatment. So this is a priority of the governor, and it is actually moving pretty quick up in Santa Fe. And really, the key changes are how it redefines harm to others to require recent past behavior showing inflicted or attempted serious bodily harm with likelihood of repetition. And it redefines harm to self to focus on the inability to meet basic needs that could lead to death or serious injury. So that really is the high-level overview of what it is. And so the update was just to communicate, where it's at. It passed in the Senate on the 23rd of January, so it's 3 days into session. It was assigned to one committee on the Senate side, and it's currently scheduled for House Judiciary Committee for tomorrow. It was originally scheduled for yesterday, so we're hoping to have an update there, but it got pushed to tomorrow. And I know our state lobbyists tried to call in, but they're actually in committee hearings today. And with that, we stand for, discussion, questions. If you require additional information for us, we could try and get that to you.
I don't know, commissioners, if you had any, Commissioner Sheldon on this?
Thank you, Chair. I think some questions that we probably need to kind of discuss, and Jamie, I'm glad that you are still here, because there's no additional funding allocated with this bill. And one of the things that I kind of would have a concern with would be kind of the CTC here in Doña County being at the forefront of this. And I kind of want to know what we think here at the county of how that's going to play out, what additional staffing needs might be needed. That's kind of one of my bigger concerns.
Jamie Michael, Health and Human Services Department, Mr. Chair, Commissioner Sheljo Hernandez. If these changes do result in law enforcement being able to engage with more people, and that results in more people coming to the Crisis Triage Center, that would be a huge benefit for the Crisis Triage Center. There is still quite a bit of capacity to serve more people. And again, the more people we serve, the more good we're doing in the community, but also the more financially sustainable the Crisis Triage Center is. So I do believe that if it does result in more people utilizing the CTC, that is a benefit for the individuals and for the financial status of the CTC. Plenty of capacity there. I know there is some concern about inpatient capacity in Las Vegas. So we did ask that the legislation include a sentence that says that it will allow, actually I think it might say direct, the New Mexico Department of Health to reimburse other appropriate psychiatric hospitals if Las Vegas is at capacity. So again, if these changes were to result in more people going to the New Mexico Behavioral Health Institute in Las Vegas, if that hospital gets at capacity, there are other hospitals in the state that can serve people. So there is suggested language in the bill that will allow the state to pay those hospitals. So right now, for example, and the reason that I have interest in those is because it puts a burden on the hospitals in our community. We have many of the psychiatric inpatient beds in Doña County with Peak and Mesilla Valley. Both of those places serve people statewide. They have the capacity to serve more people, but if the state won't reimburse them for those involuntary stays, it puts a burden on those hospitals. So there is language that has been added. So if for some reason Vegas would be at capacity and can't accept the patients, they can remain at these hospitals here, or people can utilize these hospitals here, and they would get reimbursed. But capacity does exist.
Okay, so then my other question then is, so the bill, the way that I understand it and the way that I've read it, does put CTC centers in charge of the evaluation process.
Commissioner Sheljo Hernandez, it defines them as evaluation facilities, but they're already defined as evaluation facilities in other state legislation. CTCs that are 23-hour licensed like ours, the evaluation can happen there, but it's not a must happen there. So because they're only there for 23 hours, if the qualified professional there believes that the person needs to be evaluated, they do the same thing that an emergency department does. They do a certificate of evaluation, and the individual is transported to Mesilla Valley or the Peak, and that's where the evaluation and the court hearing happen.
Okay, and what kind of liability lies on the county?
I don't have an answer to that. I don't, based on what I know, I don't think there's any additional liability, but I'm
So
not
the
the right person
CTC
to answer that question.
So the CTC evaluates me and says that I need to be committed. I go to Peak or Mesilla Valley Hospital against my will, and then I sue the county, who is the owner of the CTC. We would be liable, correct?
So the qualified professionals at the CTC fill out a certificate of evaluation, and this happens now. So
Yeah.
this new legislation doesn't change any of this. They have to meet certain criteria. We feel that this individual meets criteria for an evaluation because of these reasons. They document it. A police officer looks at it and says, okay. Then they're transported, and the evaluation happens at the Peak or Mesilla Valley, and then it goes to a district court judge, and the judge makes the determination for involuntary commitment. Both parties, there's an attorney on both sides. They both present the information to the judge, and the judge says, yes, there's substantial evidence for involuntary commitment or not.
Okay.
That's currently how it happens. This won't change that process.
Got it. Thank you.
Okay, thank you, Carrie. I'm glad you're nodding along with me.
And Mr. Chair,
Yes, Commissioner Chaparro.
thank you, Mr. Chairman. And just to follow up on Commissioner Sheljo Hernandez, those hearings happen often, and they happen at Mesilla Valley, or they happen at the Peak. The district judge actually goes to the facility, and Jamie, you're right, the attorneys from the state and defense attorneys are present with the district judge making that final decision. So the due process is protected.
Thank you, Commissioner Chaparro. Hey, I think I was kind of working through and was getting ready to ask you some questions because I think trying to understand the process. I did for Jamie, and I hate to, as you're getting your drink, I apologize. Just understanding, because maybe this is not, and I think this, this may be just like a unique case, but if there's like a minor, like a 16, 17-year-old that is going through as an adult, and would they have to go through this? And if they do, because our CTC does not provide services to those under the age of 18, is there any exceptions to that? Or is that something that just would never happen? I'm just trying to understand, because we do have the limitations in how the CTC provides services.
You are correct. The CTC is for adults 18 and older. I think there is a completely different involuntary commitment process for minors. I'm not familiar with it because we only work with adults, and I don't even know if minors, I don't think they go through the same district court process because they're
didn't know that.
minors.
Wasn't sure if, like I said, because they're minors, but, you know, there's times that the district attorney's office could choose to prosecute them as adult, and didn't know how that comes in, so.
I think because this is all civil and not criminal,
Okay.
it is very, very different. I know the criminal competency process is very different for juveniles, so I'm assuming the civil commitment, if there even is a process, because I'm not sure we can.
A lot of the times that comes back to the parents and the medical provider making those decisions together. Because unless a minor is emancipated and, you know, making their own decisions, because the parent or the guardian still has control over that, over
Yeah,
the minor's decisions.
I think it wasn't the involuntary commitment piece, it was just how the CTC was gonna pay a piece of that. If they're required to go to the CTC and they are not if they're not over the age of 18 or 18 and over, and that's what the CTC is licensed for, then what happens there? Because, you know, is there that potential? So like I said, if it is, like I'm hearing that's probably not potential there, but just was kind of curious. I think I do share the concern of Commissioner Sheldon Hernandez is, I think if, as we move forward or this happens, if it does pass, the legislature gets signed into law, I'm very concerned that there could be maybe it's not, but it may be unfounded, but my concern is that there's going to be a significant increase that will essentially eliminate the capacity that we have at the Peak or Mesilla Valley Hospital and put us in a point where, I mean, we already struggle to have these resources for just our community members. And if we overload that, what will happen? So I think that's my only concern, not so much with the law, but I think the unintended consequences of some of the changes to the law. So.
Mr. Chair, and I think the bill as a whole provides a lot more kind of clear guidelines for effective mental health interventions. So I like that part of this. It also kind of puts the Crisis Triage Center in the forefront of this whole conversation, which is nice. I think we definitely have a need in our community for this. Is the question whether or not the county should be supporting this with our lobbyists, or is the question whether or not, or is this just an informational conversation?
It's more of an informational conversation.
Okay, cool. Works for me then.
Unless we wanted to take a kind of direction on it that we want to, but I think this was just trying to get, I think when we asked for this or at least they had discussed this, I think it was just for us to get grounded on what to expect. And I think because of the behavioral health resources we have in our community, just to have that open dialogue.
Yeah. No, and I definitely think that this is headed in the right direction. I think that the Department of Health, our local law enforcement agencies, the CTC is going to have some major policy discussions and rewrites to kind of incorporate what this means for them. But that's not our purview, so cool.
Mr. Chair, if I may.
Yes, Commissioner Chaparro.
Thank you. I attended a workshop where Jamie was present and some other health care providers up in Santa Fe for the legislature. And I can't recall the name of the state police officer that, I mean, I think it'd be terrific if we could bring him down here because he was connecting services with law enforcement and the court system so well that and he was a terrific speaker as well. And his presentation wasn't all that long. It maybe was half an hour. And also, there was a prosecutor there. Can't remember his name either. But you know who they are,
Yes,
Jamie.
I know-
They were in
I
the
know who
program,
they
I just can't remember. But I thought it was very fascinating, and it would address this bill, I think, quite well and give this commission more information. Thank you.
Okay. No, I think it'd be good. I said, I think it's just one of those things that I think is where, as it's going through, it appears to have significant support on both sides of the aisle. So it seems like this is probably intended, or will be, the bill will probably end up passing. So just having those, so it'd be kind of good for us to just be aware of it. But otherwise, yes. Yeah, they approved it very first week. So now it's going through the House.
So just real quick, I am going to grab my bag and head out. Today is Behavioral Health Day in Santa Fe, and tonight they are doing the statewide Star Award banquet. And I was privileged enough to be awarded the State Behavioral Health Directors Award for the advocacy work and all the work we're doing down here. So I'm going to go off and accept that wonderful award on behalf of our county. So I'm getting on the road. Thank you all very much.
Thank you.
Congratulations and thank you. Okay.
All right, thank you, Mr. Chair.
Yeah, share it with us.
Yeah, thank you, Mr. Chair, Commissioners. And if this bill gets passed, we'll start working with the department on, estimating out, the resources that are needing and what we need to do to support the department. So,
Awesome. Thank you. All right, thank you, Lucio.
thank you.
All right, then we have just the last item, which is a closed session. And so I'll make a motion that the board convene in closed session pursuant to attorney-client privilege to discuss pending or threatened litigation related to the flood joint powers agreement as authorized by the Open Meetings Act, Section 10-15-1H7 of NMSA 1978. If I can get a second, please.
Second.
All right, I have a second by Commissioner Saldro Hernandez. If there's no comments on that, I'll ask Brandy to roll call, please.
Commissioner Shaljo Hernandez,
Yes.
Commissioner Chaparro,
Yes.
Vice Chair Gameros,
Yes.
Chair Sanchez.
Yes. And with that, we'll enter into closed session at 11:08 a.m. Okay. Thank you so much. The time is now 11:44 a.m. and we are back in open session. Let the record reflect that the only thing discussed in closed session were the items noted in the motion to go into closed session. And with that, we've reached the end of our agenda, so we will call this meeting adjourned at 11:44. Thank you all so much. Thank you for joining, and we will see you next week on February 10th for our next BOCC meeting.